Welcome to this presentation on the cardiac cycle. In this session, we will explore the phases of the cardiac cycle, the mechanical and electrical events associated with each phase, and their clinical relevance. The cardiac cycle is a sequence of mechanical and electrical events that repeat in every heartbeat. It involves a rhythmic contraction and relaxation of the atria and the ventricles, allowing for the unidirectional flow of blood through the heart and into the circulation. Each cycle lasts about 0.8 seconds in an adult, and it has two major phases: the systole, which is a contraction, and a diastole, which is a relaxation. Looking at a few definitions to help us in understanding the cardiac cycle, systole means contraction phase of the heart muscle where blood is ejected. A diastole is a relaxation phase where chambers relax and fill with blood. Stroke volume is the volume of blood that is pumped by one ventricle in one beat. Then the cardiac output is the volume that is pumped out per minute, which is calculated as the stroke volume multiplied by the heart rate. We have five phases of the cardiac cycle. That is the atrial systole, isovolumetric contraction, ventricular ejection, isovolumetric relaxation, and a ventricular filling. Let us start with the first phase, the atrial systole. An atrial systole just occurs after the P wave on the electrocardiogram. The atria contract, pushing the final 20 to 30% of the blood into the ventricles. The atrioventricular valves remain open, and while the semilunar valves are closed. This phase ensures maximal filling of the ventricles, and it's actually crucial during high heart rates. The next phase is an isovolumetric ventricular contraction. This phase begins after the QRS complex, and the ventricles contract with all the valves closed, causing an intraventricular pressure to rise sharply. This is called an isovolumetric because there's no blood that is ejected yet. When the ventricular pressure exceeds the arterial pressure, the semilunar valves open now, initiating the ventricular ejection. Then the third phase is a ventricular ejection phase, where at this point the semilunar valves open, allowing the blood to be ejected into the aorta and the pulmonary artery, and this phase is divided into rapid and a reduced ejection. During rapid ejection, most of the stroke volume is expelled. As the pressure begins to fall, reduced ejection continues until the semilunar valves close, being triggered by the dicrotic notch. The fourth phase is known as isovolumetric ventricular relaxation. Ventricular relaxation begins after the T wave, and all the valves are closed and the pressure in the ventricles falls rapidly. There's no volume change that occurs during this phase, hence it's known as an isovolumetric phase. The ventricular pressure drops below the atrial pressure and the atrioventricular valves open, making the start of ventricular filling. And lastly, we have the ventricular filling phase, where there's a rapid filling, diastasis, and atriosystole. Initially, the atrioventricular valves open and the blood rapidly flows into the ventricles, and diastasis is a slow filling period where atriosystole then tops off the ventricles, and the cycle then repeats with the next atriodepolarization. This phase is the one that ends as the ventricles prepare to contract again. We then have one of the most important diagrams in the cardiac cycle known as the Wiggers diagram. This Wiggers diagram correlates the electric and the mechanical events, the electrocardiogram waves, heart sounds, pressure changes in the chambers and the arteries, and as well the volume changes in the ventricles. Let's then have a look at the heart sounds and their relation to the cardiac cycle. The heart sounds correspond to the valve actions, where the S1, which is a lab sound, happens due to a closure of the atrioventricular valves at the onset of systole. Then the S2 is what we call the dub sound, which occurs or is produced by the closure of the semilunar valves at the end of systole. Additionally, we have the S3 and the S4 sounds, where the S3 sound is a ventricular filling sound, which may be normal in young people or could be as well pathological. And lastly, the S4 is produced when the atrial contraction happens against the stiff ventricles, and this S4 sound is always abnormal sound. Looking at the relation of electrical events and the cardiac cycle, an electrocardiogram wave corresponds to a mechanical event. The P wave is usually produced during atrial depolarization when atrial systole is happening. The QRS complex is produced by ventricular depolarization during ventricular systole, and the T wave is produced by the ventricular depolarization that occurs during ventricular diastole. The regulation of the cardiac cycle happens through a number of factors, one being an autonomic nervous system. The sympathetic nervous system is known to increase the heart rate and the force of contraction due to the effect of norepinephrine. And the parasympathetic nervous system decreases the heart rate through the vagus nerve. Another regulator of the cardiac cycle is the hormones, for example adrenaline, which is known to increase the heart rate and the contraction force. Then we have the preload, afterload, and the contractility effect of the stroke volume. And lastly, what is the clinical relevance of the cardiac cycle? Understanding the cardiac cycle helps in diagnosing the heart murmurs, valvular heart diseases, and heart failure, where abnormal timing of the heart sounds, pulse pressure variations, and abnormal filling patterns can be traced back to the disturbances in the cardiac cycle.